are age, male sex, family history, and in a small set of people, individuals, it is connective tissue disorders and aorta arteritis also form the important risk factors. Smoking, hypertension, obesity, all modifiable, and cholesterolemia, sometimes genetic. And sometimes it does help to know some physics or hi-fi scientific jargons. So in this case, the pathogenesis of abdominal aortic aneurysm, it's enough if you remember the word. It is due to increased lateral hydrostatic pressure leading to mural nutrition, compromise in the mural nutrition, and the dilatation subsequently. UK and Sweden, New Zealand and Spain, and with other few countries, they are just short of initiating a screening program for abdominal aortic aneurysm. And like anywhere else, the classical definition of aneurysm is more than 1.5 times the diameter of normal vessel upstream. So in case of, in terms of absolute number, it is 3 centimeters for abdominal aortic aneurysm. And recently there have been discussion that we can reduce this abnormal diameter criterion to 2.5. In fact, this will lead to increased prevalence. But nutshell, even right now, the definition of abdominal aortic aneurysm is more than 3 centimeters, you can call it aneurysmal. So a recent drop, obviously in the change of the lifestyle and the modification of the risk factors, there is a fall in the incident prevalence of the abdominal aortic aneurysm. So that has led to a slight decrease in the benefit-harm ratio, but in spite of that, it is pretty useful. Morbidity and mortality of the surgery following the early detection of aneurysm also needs to be considered, and obviously any screening test, the psychological consequence of early detection of the disease in an apparently healthy individual also needs to be weighed. So what is the target population? So in US and UK, it is more than 65 years of age male patients, and all of us, we know that Asians, the atherosclerotic process strikes a bit early, say about 5 to 10 years. So maybe we can think of 55 to 60 years as the criteria for screening the Indian patients, and annual is probably the best. And in this regard, the US Preventive Services Task Force has come up with few guidelines, and it says men aged between 65 to 75 years and who have smoked at least 100 cigarettes, they need to get screened for aortic aneurysm. That is one-time event, and definitely benefits outweigh harms. And as I said earlier, the possible complications out of surgery following the early detection needs to be borne in mind. And not all randomized controlled trials have shown the benefit in favor of screening. So that also we have to keep it in mind. And screening tests, so what are the screening tests we have? And obviously all of us know from our community medicine practice, it is to be easily doable, repeatable, and naturally less invasive, so radiation hazard should be less. So one of the things is abdominal palpation, but all of us know, even though clinical acumen is quite important, we also know the fallacies of the clinical examination, even at the best hands. So ultrasound is the ideal modality for screening. So general instructions, fasting for 3 to 4 hours will do a lot of help. And if the patient is diabetic, obviously diabetic meals can be had. And if still he wants to have half a cup of tea, coffee, or half a glass of water, will not hinder the evaluation of the abdominal aortic aneurysm by ultrasound. CT MR ordered for other indications. Patient had some other abdominal disease and he has been imaged, and you look at the CT with respect to aorta. So that also can serve as a screening tool between 65 to 75 years. And this is the recommendation from US force. If less than 30 millimeter, no further screening, and if the aneurysm is small, that is 30 to 39 mm, surveillance interval is about 2 to 3 years. And if the medium size, that is 40 to 54 mm, 5.4 centimeters, so 6 monthly screening is recommended. And more than 54 mm, and this is the guideline taken. In fact, this number has varied from 5 centimeters to 8 centimeters. But in general, you can take it as a reference of 54 mm. It needs active intervention in form of either open surgery or endovascular. 6 to 6.5 centimeters is the number for those patients who have connective tissue diseases or aorta arteritis. So you can notice that just 1 centimeter buffer is given for this small group of susceptible individuals. So again, one more question to be addressed is whether should we